Just to let people know that there are headsets outside for any translation. So if anybody needs one, they're just outside. I'm Helen Platt from the Union, and just before we start today's session, we would like to present one of the Union Awards. I would love to introduce Dr. Paramasivan from the Union Tuberculosis Section Chair, who's going to present this Union Award this morning.
Good morning to you all. As you all know, the Karel Stiblo Public Health Prize acknowledges a health worker or a community organization for contribution to TB control over a period of 10 years or more. Dr. Rohit Sarin, the present recipient, has an experience of more than 3 decades in patient care, research, teaching, and advocating for TB control, both nationally and internationally. He has been in the forefront in formulating, implementing, and promoting India's revised National TB Control Program since its inception in the early 90s. He is the director of the National Institute of TB and Respiratory Diseases in India since 2012. Dr. Sarin has been dedicated to the field of TB and lung diseases for more than 33 years. The award particularly recognizes Dr. Sarin's key contribution to DOTS and MDR TB treatment both nationally and internationally. It gives me a great pleasure to invite Dr. Sarin to the stage to accept the Karel Stiblo Public Health Prize. Dr. Sarin, please.
A very good morning to all. I'm really overwhelmed at this honor which has been bestowed on me by the Union and all of you fellow TB workers who have contributed in the growth, not only my personal growth, but the growth of the TB control activities. On this occasion, I thank the Almighty for having blessed me with this particular honor. And I thank all my TB patients who have been my learning over the years, ever since I entered into this area in the early 1980s. My thanks are due to my other teachers, colleagues, friends. And in fact, I still remember the day when I met Dr. Karel Stiblo in India, and he guided me into this particular direction in the 90s. I can only say, friends, that yes, the distance we've traveled is large. We've come a long way, but the last mile is going to be much more difficult. Efforts have to be more aggressive if we have to achieve what we call as the End TB strategy. Thank you so much for making me a partner to this particular effort, and I hope I'm able to deliver and see the TB melody coming to its closure. Thank you so much.
Well, good morning, everybody. Thank you getting up early and coming to. What a wonderful honor for that. So congratulations once again. It's just terrific. It's so rare that we actually honor the people that are right in front of the problem. And so this is very gratifying to see the acknowledgement. I want to thank the organizers, the union, for convening this panel this morning. I think it's at an extraordinarily appropriate time that we look at the road to the high-level meeting in September 2018 and see this as an opportunity to focus the cumulative work of all of you in this room and all of our colleagues outside who are not attending to translate the experience that tuberculosis has had on a global level to those individuals who are in a political position to understand and then make an allocation decision in their respective countries. It is time for the science to be translated to the policymakers. You, as individuals, are in the best position to do that. Your understanding of the science and the data needs to be manipulated so it can be understood by those who do not have medical backgrounds, but who control prioritization of unmet need and make the allocation decision. You need to know who these appropriators are in your legislatures, and you need to take it upon yourself, insofar as the bureaucracy you're in will allow you to do it, to tee up a dialogue with staff and principals themselves about the urgency of the tuberculosis burden, the 11 million new infections each year, the close to 2 million deaths occurring in a relatively small number of countries, but at the same time everywhere on the planet. Every country has a role to play, but will not understand that role unless they understand their respective burden of TB in their country. I have been in country dialogues with appropriators, and essentially every time the information is new, and they are startled by it and see this as an issue that they need to engage with. So I want everyone in the room to be aware that this is a unique moment in the progression that you have all been working on year after year after year, and we finally, in the next 14 months, have an opportunity to put the issues that you confront daily on the world stage and describe them in such a way that the individuals understand the missed opportunities, the tragic tragedy of a disease that we can diagnose and treat, but cannot put a delivery system up and sustain it long enough to take an individual through 6 months of treatment and allow them to return to a healthy life. These political discussions, I just want to say, are informed and enhanced when expertise comes in to, as I say, explain the science to the policymaker. I think one of the critical translations that often does not occur in the typical budget preparation is internally within the ministries of health. There's a lot of data that gets digested, responded to, and thrown north. But the ability to explain that data to the individual or committee that is making the allocation decision is a rare event. and I would encourage you to look at the mechanism that would allow you to do that. The political moments are the result of efforts both from the scientific side of it, but are really enhanced and realized through efforts of the community. Our ability to embrace the community and expect the community to carry this message as well needs to be something that each of you in your respective settings orchestrates, creates a cadre of well-informed advocates, patients that may or may not play a role in your facility, but can be identified to be that spokesperson as those discussions occur. The ability to translate it to an individual, to make it a person, is much more effective in talking to political policymakers. So I will now have Sabu go ahead and go through a little of the data, and then we'll go into the discussion.
Thank you. That was Dr. Eric Gusby, UN Special Envoy on Tuberculosis. Needs no introduction. All of you know him. I am Suvanand Sahu from Stop TB Partnership in Geneva. And I will just take less than 5 minutes to walk you through one slide and maybe leave you with some others, just to focus the attention on the UN high-level meeting. This is yet another jargon in the TB world, new one, UN HLM. Can I have the next slide, please? Can I have the next slide, please? Yes. So I think at the outset it is very important to be aware and have a kind of vision about what is success, what is a good UN high-level meeting for TB that everybody will be happy about. And we have been thinking about it, and a few things to focus your attention on. On the left side of the slide, you see the processes, and on the right side, you see the outcomes. In terms of the processes, we need to see that at least 40 heads of state, this is not a magic number, but people thought 40 would be a good number. If it's more, it's better. But at least 40 heads of state, not ministries of health that we always have, but this is at the UN General Assembly, so it should be heads of state. Then there should be an action-oriented political declaration endorsed by heads of state. 2 days of meeting during September 2018 in conjunction with the General Assembly of UN that happens that time. The dates are not yet fixed, and also the number of days are not fixed. But I think 2 days, and in the middle of that UNGA meeting time is the ideal time to have this. Then the last one, very important, there should be a strong civil society involvement, including a robust involvement of CSOs in all aspects of the UN HLM, a civil society consultation hosted by the UN Secretary General, inclusion of CSOs in government delegations to the UN HLM, and involvement of CSOs in the accountability mechanism that will be proposed. In terms of outcomes, we need to have a set of high-level political numeric targets for 2020 as well as 2025, linked to the global plan and the NTB strategy, because these are documents that everybody has agreed to, and the TB world is fully behind it. There should be an accountability mechanism which includes regular reporting back to the UNGA, because this is not just one-time activity, but this needs to be followed up. There needs to be an agreement to hold a UN high-level review meeting within 4 years of the UN high-level meeting. Strong targets and commitments on human rights, gender, and vulnerable populations. And commitments to numeric targets on finance for implementation as well as research. And we know the needs of how much is required for implementation and research, but we need to turn that into targets. So this is what we thought would be success, and we need to all work towards it. I will just leave you with two things. One is that we need a process to reach there, and already there is some work happening. There is a coordination group which includes all the stakeholders. There are 8 tracks which have been proposed, and you can see the names of the track there, but I will not go into the details. But this is to involve everybody and make this inclusive. And last, I will leave you with some thoughts about, there are several opportunities, high-level opportunities coming up between now and the UN high-level meeting. And each one of them we need to utilize to get TB to the highest level and to get to what we need, the heads of state and whatever we need out of the UN high-level meeting. I will not go into the details, but several opportunities you can see, and also running up to 2018 September. So I will end at this. I will now invite our speaker. We have 3 speakers. The first one is Chief Wilton Littlechild. He is the civil society and Indigenous people representative from Canada. Please.
Good morning. Nigan kahkyo tatam skadnao. Mstaki goma hemam skotama ngeton. Miaya wenoche. I just bring you greetings in my language. My Cree name is Mahikant Mohteo, and I'm the chief of Treaty 6 territory in Canada. Athletes always set a goal or a target for performance. And I want to commend you for your goal that you've set at this assembly, accelerating toward elimination. My focus this morning on the road to the UN high-level meeting is to focus on an Indigenous legal framework. We started on this path actually 40 years ago. We wanted to ensure justice happened for Indigenous peoples. The framework that I want to discuss, I believe, will help us accelerate our work to eliminate tuberculosis, especially among Indigenous peoples. First, I want to give a little background. If I may show the first slide, please. For almost 100 years in Canada, there was a policy of setting up Indian residential schools. Now, the stated policy of that era was to kill the Indian in the child. To kill the Indian in its child. This history in Canada is the most unknown, it's the saddest and darkest chapter in Canadian history. The largest class action lawsuit in Canadian legal history resulted in a truth commission to be established. What happened in these schools? What happened to the children that were taken? Well, you'll see the building. There's a structure as an institution where children were kept like I was. I spent 13 years in 3 different residential schools. The truth of what happened was the most horrific stories of abuse, physical, mental, cultural, spiritual, and worst of all, sexual abuse. I knew the abuse was there. What I didn't know was the depth of the abuse of children for all these years. We went across the country holding hearings about what happened in these schools. One of the stories that we kept hearing about was the death of children in these schools. This is a court-ordered truth commission, but one of the things that was not included in the mandate was the children that died in these schools. The number one killer of the children in these schools was tuberculosis. That's why I'm so honored to be here this morning. Just 2 weeks ago, in a newspaper report in Canada, I'm going to refer to it if I may, and I apologize for reading it. But it's also estimated that over 4,000 children died in these schools. However, that figure is masked because many times children were sent home when they were sick. So they died at home with TB, and it may have not been recorded, or they would spread it within the family. So this story that I want to share with you is about reconciliation. In our report, if I may show the next slide, please. I wanted to give you a different perspective of this school, because my sisters and I went here, and unfortunately you cannot see, but there's a wire in front of that school, a fence. Some people say, well, so what? Well, it was a barbed wire fence, and they say, well, get over it. That was an electric fence. That's what kept me and my fellow students in this building. So, tuberculosis is a very important part of reconciliation in Canada. This article was 2 weeks ago. Just last week, a couple of days before I prepared to come here, there was another article in the Canadian newspapers. It was about lung disease killing a 15-year-old girl in one of our northern communities in January, tuberculosis. And in a report, because a task force has now been established to look at the situation, in the report it says, among the Inuit, which are Indigenous peoples in Canada, the tuberculosis rate in 2015 was 270 times higher than the rate among Canadian-born non-Indigenous peoples. That was just a couple of days ago. So, the truth now, as I say, informs reconciliation in Canada. And a part of that, if I may show the next slide, in our report, we use themes of how we believe after a 6.5-year study, we can have reconciliation in Canada. Health is one of those. It's a very, very important chapter in our report because, as I said, tuberculosis was the highest killer of children in these schools. Now let me go to the reconciliation. After almost 7,000 stories, we as commissioners sat down and said, what is it that's common in these stories? And the first principle we've come up with as a conclusion is that the United Nations Declaration on the Rights of Indigenous Peoples is a framework for reconciliation. So when we go towards this high-level meeting, The rights of indigenous peoples are there. The world, by consensus, has adopted the UN Declaration. So it would be important to reflect on the rights of indigenous peoples as we go towards this journey to the UN high-level meeting. Our commission issued 94 calls to action in Canada. 16 of those calls to action are underpinned by the UN Declaration on the Rights of Indigenous Peoples. 7 are about health of Indigenous peoples. There's also a report that was done by the United Nations itself, by the Expert Mechanism on the Rights of Indigenous Peoples, that talks about the treaty right to health. So when we go to the UN, we need to reflect not only on a general right to health, but the specific right to health of Indigenous peoples. It's well noted in reports. There are other international meetings that can guide us on this acceleration. The World Conference held at the UN just 2 years ago also adopted a declaration that recommitted states to promote and respect health rights of Indigenous peoples. The Sustainable Development Goals that the world is going towards now also has an article on health. The Business and Human Rights Framework also talks about health of Indigenous peoples. We talk about the state obligations of Indigenous peoples, and we need to underscore these responsibilities. So on the road to the UN, if we want to accelerate towards elimination of TB in Indigenous peoples, there is an existing legal framework there. What we will need is political will. Political will for a rights-based approach. My most respectful view is that what we need to do is call on the UN member states for implementation. Implementation of not only the right to health generally, but the right of Indigenous peoples to health specifically. Commitments on the rights of Indigenous peoples, that's where we need to start. Hi. Thank you very, very much.
Thank you, Chief Littlechild. Now, the next speaker is Professor Michel Kazanskin. He is the UN Secretary General Special Envoy on HIV/AIDS for the Eastern European and Central Asian region.
Thank you very much. Good morning, everyone. It's a pleasure to be here. TB, no doubt, is a global health crisis, and it is a few weeks after the publication of the WHO Global TB Report of 2016 that member states called for a UN high-level meeting to be held in 2018. This is the first time for TB. It's not the first time in global health, and this slide shows a number of such steps or issues where that sort of moved up from Geneva to New York, that is, to a much more political environment. HIV/AIDS came to the Security Council in 2000. The first UN General Assembly special session on AIDS took place in 2001, and then every 5 years. And as mentioned yesterday in President of Uruguay's remarks, a similar process went on with non-communicable diseases with the first UN high-level meeting in 2011, 2014, and next year, 2018. It is, of course, the General Assembly in New York that also adopted the Millennium Development Goals in 2000 and the Sustainable Development Goals in 2015. I truly believe this is a remarkable opportunity for TB. It will be a way for TB and drug-resistant TB to be recognized as a global public health crisis by the international community. It will mean TB to be further prioritized within global health, and TB to be prioritized in the next 2 years as we prepare for the UN high-level meetings in multilateral health diplomacy and on the political agenda, because as Sahu just indicated, the end product of that General Assembly will be the adoption of a political declaration with a number of targets. You may, for example, be familiar with one of the targets that the political declaration following the 2016 high-level meeting on AIDS took, which is a reduction by 75% of TB-related deaths among HIV-infected people by 2020. And I believe this will also help TB to be prioritized within the more broad Sustainable Development Goal agenda. I would like to focus for a few minutes on points 2 and 3, that is, discuss with you the context of TB within global health and the context in which global health is and will be in the next 2-3 years as we prepare for the high-level meeting. Global health, I would define here as referring to health issues that transcend national boundaries and national governments, which means in turn that these issues call for collective action on the part of the international community on their determinants. Collective action meaning coming together to set a frame for diagnosis, prevention, and treatment, but also for the international community to come together and to close the funding gap on TB and the funding gap on TB research that is so needed. Global health in general is a very broad field. It is a political, medical, scientific domain that is anchored in the interdependent world in which we now live, the globalized world. And as you know, a globalization that is, in fact, characterized by increasing inequities in living conditions, in resources, in access to medicines, and international trade. And all of these elements have impact on health. It is a domain that asks political questions and therefore calls for political answers. The political process here is to actually negotiate the political choice of health or negotiate the political choice of TB in face of other interests of political, social, or economic nature outside the health sector. So this is an example of some of the issues that are currently debated in global health, the major pandemics, of course, obesity, diabetes, non-transmissible diseases, antimicrobial resistance, access to medicines, universal health coverage, WHO reform and governance of global health, and of course, health in the context of the Sustainable Development Goals agenda. Now, global health is not a separate field somewhere outside there. Global health, of course, is tightly associated and interlinked with national strategies and with what happens at local level. There's no way a national strategy can be dissociated from the global effort, and the similar relationship exists between national strategies and more local strategies. The role of a Minister of Health in 2017 is not only to take care of the health of his citizens, but also to contribute to build a more healthy global world. Now, global health and all of these concepts started in 2000 or end of the 90s when we were talking about global public goods. And of course, with the MDGs, and as you remember, 3 of the 8 MDGs and 40% of the indicators of the MDGs were somehow related to health. And during that period of the MDGs, remarkable progress has been made in fighting the pandemics, particularly in reducing child mortality, reducing absolute poverty. There was translation of significant progress in research into large-scale public health programs, a significant increase in resources devoted to health, new actors, new institutions, new funding streams, new models of health governance. However, the progress on MDGs has been unequal, and some of the health crises, such as Ebola, that occurred in the last 3-4 years, really question whether these new institutions and these new funding streams have really translated into strong, robust, sustainable health systems and in an effective, decisive health governance. And this is true for TB, which I feel, I'm sure you feel, is at both the times of opportunity and of high risk. Opportunity because we've seen the remarkable progress, the decrease in incidence, the decrease in overall mortality, but we've seen also very unequal progress around the world. We know a large proportion TB cases still undiagnosed, people left behind, including socially disadvantaged citizens, people who inject drugs, migrants. And we're seeing a dramatic increase in DRTB incidence and a continuing increase in HIV-TB co-infections in several parts of the world. And of course, insufficient resources devoted to research to advance TB control. And that happens in a hugely fragmented global health landscape. You will recognize here intergovernmental negotiations, high-level meetings such as the G7 or the G20, the UN bodies, including WHO, the public-private partnerships such as the Global Fund, philanthropy such as the Gates Foundation, MSF and civil society actors, activists, a hugely fragmented landscape, and all of these people will be involved in negotiating the outcome of that meeting in 2018. So health governance is currently fragmented. Of course, we all recognize the key normative role of WHO, but we also see that fragmentation in terms of, for example, funding streams, and a very multipolar landscape. Multipolarity opens the door somehow to people defending their own interests or some powerful people imposing on less powerful people. I would, however, propose that fragmentation is not necessarily a bad thing. And as an immunologist, I've always thought polyclonal antibodies are better than monoclonal antibodies to defend ourselves against infection. And to me, that fragmentation is somehow an institutional adaptation to the context. The intergovernmental process at the UN would not have allowed a civil society and government coalition such as the one we see in the Global Fund if that had stayed only intergovernmental. Now, that global health landscape is facing a global picture of the world today. which we have to keep in mind as we negotiate for health and we negotiate for TB within that world. First, a globalizing world, I keep repeating it, an interdependent world with very new demographic trends. One of these is the fact that most of poor people now live in middle-income countries. If you look at the red column to the left, you can see that almost 4 times more poor people, defined as people living with less than $2 a day, live in middle-income countries as compared with low-income countries. And to the right, you can see that with regard to HIV/AIDS, basically 2/3 of people with HIV/AIDS now live in middle-income countries and 1/3 in low-income countries. I couldn't get the figure right for TB, but I'm pretty sure it's somewhere very close to that. It is a world that characterized by increasing urbanization, by commercialization, including in the health domain, by new patterns of inequities, with inequities growing now within countries rather than in between countries, new economic powers, and multipolar geopolitics, no more a global north and a global south as in the year 2000s, but actually multipolar balanced geopolitics. And it is a world where health is no more just on the development agenda as it was in the MDG era. It is now a world where health is a security issue, and AMR, of course, is a key security issue. It is a world where foreign policy takes over and where a number of national interests are defended in the name of or using health. It is very high on the economic agenda with a $1 trillion industry, health industry, and it is, unfortunately, of course, very much on the social justice and human rights agenda. And finally, health is now on the global crisis or global interdependent crisis agenda, such as environment. You will see from that some of the decisions that are key to health are not taken by us in the health sector. Everything that deals with the environment, is taken as decisions by environment ministers. Everything that deals with the impact of, sugared drinks on obesity, these decisions are made in boards of multinational companies and not in ministries of health. And finally, there are new challenges maybe emerging in the last 2 to 4 years, which I'd like to depict here. A weakening multilateralism, less appetite for multilateralism. And this paradox, which I hope you will recognize, the more we are in an interdependent world and the more we go for sovereignty and nationalism in the face of increasing interdependence. There is an increasing political nature of global health agendas. Just think of some of the threats on the funding for sexual and reproductive health, what I call the clash of norms and ideology, that is in the name of ideology, not recognizing the scientific evidence, let's say harm reduction for people using drugs in some parts of the world. The fact, as I mentioned earlier, that some key decisions for health are taken outside or even without the health sector. And finally, a hugely disappointing lack of progress on the key issue of the link between access to medicine and intellectual property. So if you weren't convinced, please keep in mind that health is a political choice, health is politics, and TB will be, in the next 2 years, a political choice at all levels of governance. So how do we move forward in the 2 years to the UN high-level meeting? Responding to these challenges will require an understanding of the changing world and evolving international relationships, which was my point today. It will require interfaces between different governance domains, civil society, philanthropy, governments, various sectors in governments. It will require cooperation between different actors from the public sector, the private sector, the civil society, on the basis of shared principles, a sort of shared global ethics and shared concepts of security, justice, and governance, because we are in a world of a shared global space. We are in a shared risk space, and therefore we have to be in a shared global space of responsibility. Now, when we negotiate health or when we negotiate TB, we have two strong pillars on which we can rely that maybe other areas of diplomacy wouldn't have. One is the role of science and scientists and evidence, and thus your role, the key role of the interface between diplomats and health experts, will be critical for successful outcomes. And the second is the value base, that is health equity and human rights, because we in the global health arena are driven by equity as the driving force of the global health agenda. So in conclusion, we are in a global world, and we now have both national and global health interests. And governments must be held accountable for both. And you, as citizens, must have your governments accountable for what they do for their country, but also for what they do to build a healthy world. We need to collectively accept a set of key principles that I call here global health ethics, and work to produce global public goods. And we must think, as was discussed yesterday evening by at least two speakers, think beyond TB and beyond health, and embrace a broad notion now of sustainable development linked to the SDG process. And finally, in a very fragmented landscape of health and TB governance, we must learn how to govern a global system and making it more equitable and just. Thank you.
Thank you, Michel. Now we have Dr. Jeremiah Chakaya, President of the Union.
Thank you, Sahu. And first, I'd like to say a big thank you to the organizers of this plenary session for the opportunity to speak here. I think it's a big honor for me, and thank you very much for that. While thinking about what to say here and whether to prepare PowerPoint slides or not, I made a conscious decision not to use PowerPoints. And I knew that you will already have been given the figures about how much TB there is and how this UN high-level mission is so important to the TB world. And so I thought maybe I would deviate a little bit and tell you my personal story, my journey through my profession as a TB doctor, because I think that has important implication for the work that we are going to do going forward. So many years ago, as a young medical doctor in Kenya, working at the infectious disease hospital, still wondering whether to become a cardiologist or a respiratory physician or a gastroenterologist, and wondering, do I want to make money or do I want to serve the public? I worked in the infectious disease hospital, and one afternoon, I lost a 22-year-old university student who had been in the ward for 3 months with tuberculosis, receiving treatment for tuberculosis, and we were all wondering why her smears were not converting. And the day she died, while the nurses were cleaning up her bed, they found that all the medicine that she had received for the 3 months were all packed under the pillow. She had not taken a single tablet. And she wrote a small note at the end that there was no point in taking treatment for TB when in fact I know I'm HIV infected and I'm going to die anyway. The poor girl did not know that we had in fact tested her. Those were the early days, and she was HIV negative. but she died thinking she was HIV positive because everybody thought that HIV, TB is associated with HIV. So if I have TB, I have HIV. The following day, I lost a young man who was about 19 years old, who had been treated for TB 2 years ago and developed chronic pulmonary aspergillosis. As you all know, chronic pulmonary aspergillosis is associated with one symptom, that's hemoptysis. And while he was waiting for surgery, he died. And he died because he coughed out blood. Coughed out so much blood that we could not save him. Those two patients made the decision for me to work with TB. I committed to work with TB, and I'm going to hopefully end my career as a medical doctor working for TB. But it's a bit unfortunate. When I got into TB, the burden was huge. 1993, WHO says tuberculosis is a global emergency. And that was about the time that I entered into the area of TB. Then we saw the numbers coming down slowly. Case notification was going down, and we were all very happy. Until 2 years ago, or rather 2016, when WHO said, no, you guys are making a big mistake. There are actually more cases of TB than you think there are, and TB is causing more deaths than you think it is doing. That was a major setback for me as a TB doctor. A great setback indeed. So I've been asking myself, where did we go wrong? Why is this germ so stubborn that we cannot get rid of it and get it out of the world so that people can live without TB? We think we have great ideas, great strategies. We had the DOS strategy, we had the Stop TB strategy, and now we have a great one called the End TB strategy. We think we have moved with the tools that we can use to fight this disease called TB. But we have a problem. The application of those tools, poor as they might be, not as optimal as they might be, but the application of those tools is inadequate. So the UN high-level mission that people are talking about is a great thing for me, because I think it might just end up doing the kind of things that many of you in this room are expecting it would do. But I'm a little scared. And I'm scared because we have had declarations before, and those declarations have not led to anything. 2001, my heads of state from the African region met in Abuja and said 15% of our government money will be spent on health. If they had done that, we would have great healthcare systems. With great healthcare systems, we would have a background, a base on which our TB responses would be a little more robust than they are today. Today in Africa, very few countries are spending that kind of money on health. And that also means very little money on TB. A few years later, African health ministers met in some country, can't quite remember where, I think it was Maputo or I think it was Maputo. And they said TB in the African continent is an emergency, and they had a raft of things that they said they will do to confront TB. Not a single one of those countries has done anything in that respect. So we are going to the UN high-level meeting. It's going to happen. For sure it's going to happen. And there will be a raft of things that we will say we will do. How assured are you that the patient who lives in my rural home, who has to walk 10 kilometers to the nearest health facility, will benefit from what will be discussed in Washington or New York or wherever the UN high-level mission will be held? What am I trying to get to? I think there is a big need to have advocacy efforts that really lead to tangible results. The UN high-level mission meeting is one of those things, and I really congratulate those who have pushed for this meeting to happen, because I think that's what we need in TB. But I don't think it is by and on its own the end game, as it were. To me, that UN high-level meeting, when it happens and commitments are made, I would want to see those commitments implemented. I would want to see follow-through action for those commitments to mean something to the patient in my rural home, to the patient in a slum in Nairobi or somewhere else in this world, and to the communities that are affected by this disease called TB, and to the healthcare workers who often have to work under very difficult conditions to treat the TB that we'll be talking about here for the next 3 days or so. It must mean something more tangible. Health systems must be improved. Today, you walk in many countries in this world, they have terrible healthcare systems. Human resources for health deficiencies are huge. Procurement and supply chain management systems are very weak. Health information systems is horrible. Those are the kind of situations that we want to see a change. And if the UN high-level meeting is going to do it, then let it happen, because it's going to mean something for us. Today we say we don't have as good tools as we want them to be. The gene expert test was a great test for all of us, but we know it doesn't do the job because it is a little more expensive and we can't use it in certain parts of the healthcare system. And therefore we want our point of care test, we want better drugs, we want to treat TB in less than 1 month and things like that. So what does the UN high-level meeting do for us? I am hoping that once that meeting happens, there will be more money that will go into research so that these kind of things are sorted out. And it's not just research to develop new tools, but research to make those tools applicable at the lowest level of the healthcare system. So we must take implementation research, we must take applied research or operations research or whatever we want to call it, but research that makes sense to the people who are delivering services at the most peripheral of all levels. So I think my message is one. This is a very exciting time for us in the TB world. We have wanted, we have desired, we have hoped for this kind of thing to happen, and it's about to happen. This meeting will happen. I think it's going to happen. I don't see it not happening unless the world comes to an end tomorrow. And the world is not going to come to an end tomorrow. So this meeting will happen. But I'm begging us to think beyond this meeting. What advocacy platforms do we need to put into place to ensure that governments commit to whatever they will say they will do when they sign on the dotted line in New York when that time comes? We don't want them to pop up champagne bottles, come home, and then it's business as usual for the next 10, 20 years as TB continues to kill people the way it killed that young lady that I was taking care of 24 or so years ago. Thank you very much.
Thank you, Dr. Chakaya. We have a few minutes and we would like to have your responses, maybe 2 to 3 questions, comments. There is a microphone here. If you can identify yourself and then speak, that'll be great. And after that, we would request Eric to conclude the session. Yes, go ahead, Ken.
I don't know if this, okay, thank you. Good morning, thanks to all the plenary speakers in the panel. And thanks, Jeremiah, for your very sobering reality, harsh reality-based test. However, those of us who work in the field are pathologic optimists. We need to get this done. This is our chance. What I wanted to get back to, Sahu, I think it was in your slide, where you showed the process and the desired outcomes. One thing that struck me is that the status report was 4 years later. The way I look at this, and pardon me for falling back on my medical background, when you have someone who's really sick, you put them in an intensive care unit and you want the vital signs taken much more frequently than every 8 hours or once a day. I think we're going to be in dire need of keeping a finger on the pulse to make midterm corrections and not wait for 4 years to determine how well are we doing, what are the remaining obstacles, and how do we overcome them to make progress. Because we keep taking the cues from a slow-growing organism, and we really need to accelerate the pace. So I wonder if those in the panel have any comment about the time frame for the updates to be provided to the United Nations. I know they deal with many other things, but at least written reports that could be discussed without a session in particular, so that we can raise any outstanding issues to that level. Thank you.
Thank you. David?
Yeah, David Bryden with Results. I was really moved by Dr. Chakaya's remarks, and I just wanted to appeal to everyone in the room and everyone listening to get out of your comfort zone, engage in advocacy to make this meeting at the UN something real and something meaningful. That means maybe taking off the hat of the scientist or the hat of the implementer, following Ken's example of engaging in advocacy, because those of us who do advocacy, like myself, we are few in number, and we need you. And the second point was, our question, how do we interest funders to really support advocacy even more? And I'm thinking I'm really inspired by what Stop TB Partnership is doing in that regard, but also Louder Than TB. That tremendous little exhibit at the front entrance, that's creative, that's interactive. We need to see more of that kind of thing, not just advocacy for a narrow set of people talking to another narrow set of people, but really engaging the general public. And I think that's sometimes looked down upon as, oh, well, we don't need to do that. Actually, in TB, I really think we do. The public needs to perceive TB as a serious issue, and we shouldn't just rely on the free media that we get, but we need to really make this real.
Thank you. Okay, we will just take, that's the last one, if it can be quick.
Yeah, I'm going to be quick. My name is Yed Mahirsi. I'm from Tunisia. I'm a member of the TB Community Advisory Board. So basically, I've seen the timeline leading up to the high-level meeting, and my question is in two parts. One, how are we going to make the 40 head of state show up in the room? Are we investing on national level? Are we, what's the strategy around that? Is there enough support throughout the year to make sure that this presence is going to be ensured? Because I'm not seeing anybody involved. And actually, I want to invite everyone in the room to check with their national government if they're willing to attend the high-level meeting and if there is anything we can do to help them attend. The second thing that I feel is crucial is the participation of communities in this whole process. We have the high-level meeting scheduled for September. That means we basically have 15 months to get the communities mobilized so we can see them also in the pictures. Because so far, it's really rare to see communities of people living or affected with TB that are present and advocating and pushing for more funding, but also for equality in terms of access to treatment. Thank you.
Thank you. I will start with some quick reaction to what Ken said, and I would invite the panelists also to respond. What I meant in that slide was a review after 4 years, but regular reporting back to the UN high level. So I guess that would mean a yearly report back, but I'm not fully aware of the process. But yes, you have a good point that it has to be regular reporting back and not after a certain number of years. Any other, anybody would like to? Yes, please, go ahead.
Excuse me, I just wanted to request something from all of you going forward. When you have discussions like the objectives and the timelines and all of that plan, you use the term civil societies. When you use that term, at least in the international arena, especially at the United Nations, it tends to exclude indigenous peoples. So if I may suggest, phraseology, civil society, and indigenous peoples so that there's a specific focus on the health of indigenous peoples. Thank you.
On the last two questions, I'd just like to say that, of course, we have to base our advocacy on the evidence, and that's why the role of science is so important, and why the evidence and the science is so key to what we call health diplomacy, which is what will take place in New York. But it isn't about just defending TB as such against anything else. It is bringing TB as a key component for global health, for development, and for what I think will be the driving force of the international effort in the next 5 years, which is leaving no one behind. I think this will be the number one strong driver of the Sustainable Development Goal agenda. And in the TB world, we have so much to say and so much to do about leaving no one behind. So let's keep that as a sort of driving force for advocacy.
Well, thank you for the patience, and I think attention from this panel's discussion has highlighted a number of issues that I think are relevant to all of us in thinking about our individual marches to this high-level meeting. Thinking about the inequities and the disparities that are in front of you as providers of care, as researchers, as those in the health profession who implement programs. It is those examples, those experiences that communicate most strongly to appropriators. In your own clinical settings, for those of you in them, being that individual who begins to create a drumbeat in your own institution about these issues specifically, stimulates the population that uses these services, the patient populations, the people that are using them. It stimulates the self-expectation that they too are empowered to engage in these discussions. This year is our opportunity to put all of that together and have it precipitate on that, on that September Monday, Tuesday, and Wednesday of that week. Anything that we can do or help you do to bring that voice to that discussion, this is the time for us to make that extra effort on top of all the work you all do to try to fill the time in those 3 days in the UN high-level meeting. It really gets down to that. I want to thank you all for the work you do, the lives that you touch, and the people that you interact with and empower. Optimism, as my colleagues on the panel have said, is an essential ingredient to this effort. There should be honest intellectual honesty around the challenge, but there should also be a clear beaming light of hope at the end of this tunnel, because most all of the problems that we're in front of either have adequate solutions, the R&D is teeing up and getting in queue, but it all needs to come together in an orchestrated effort at the local level, and that's the challenge. The resource deficit is the main rate limiter. So a resource bolus will be the most likely reflection of a successful high-level meeting. So I just want to say that I want to thank the panel for their time and effort in the preparation of the talks. The complexities of TB are there, we all know that, but our job is to help the global leaders see the potential and the vision of a world without TB. So thanks very much.
The message is loud and clear. Nothing is possible without the civil society and the affected communities. The Global Coalition of TB Activists, with over 300 members from across the globe, is willing, ready to partner with you. We urge our governments to take that step to include us. We had a great message and a very sad story about exclusion. We can't make this go on anymore. So the message we want you to take back is inclusion. Let's do away with exclusion. Let's do away with discrimination. Include, partner with us, not as a tick mark in a box, but really let's join hands to make this HLM a huge success so that the unnecessary deaths from a curable disease will at least begin to come down. Thank you very much.